Go ahead and press record. Great. Welcome everyone to the Oregon Health Policy Board's December 13th educational webinar on Oregon's healthcare workforce needs assessment. Before we get started with today's presentation, I have a couple housekeeping items to cover. Just so you all know, today's educational webinar is being recorded. So if you'd like to go back and review the webinar or share it with anyone, that will be available on the Oregon Health Policy Board's website. I'll drop that URL into the chat. And also, just so everyone's aware, the educational webinar is for informational purposes only, and no Health Policy Board business will be conducted. And during the webinar, all participants will be placed on mute. But if you have a burning technical question or clarifying question, go ahead and raise your hand or send me a chat and we can make sure that the presenters can address those. Otherwise, we will hold questions till the end. And we will prioritize taking questions from board members first. And then if we have additional time, we will take questions from other audience members. And that's because the board will be reviewing the needs assessment and voting on its approval at its meeting next month. So we want to make sure the board members are aware. All right, I think that was all I wanted to cover for our housekeeping. I have some bios to read. We have 4 presenters today, so thank you all for being here. We have Tao Lee, who is an assistant professor in health management and policy program in the College of Public Health and Human Sciences at Oregon State University. Dr. Lee's research expertise focuses on implementing economic evaluation methods to inform decisions about healthcare investments. He has conducted research projects to empower various healthcare workforces to advance value-based and patient-centric care. Jeff Luck is an associate professor of health management and policy at Oregon State University's College of Public Health and Human Sciences. His research focuses on performance of healthcare delivery systems, health insurance programs, and the public health agencies. Dr. Luck is a member of the Health Plan Quality Metrics Committee and was a founding member of OHA's Metrics and Scoring Committee. Veronica Irvin is an associate professor in the College of Public Health and Human Sciences and the Celia Strickland Austin and G. Kenneth Austin III Endowed Professor in Public Health. Her expertise spans more than 15 years and uses a community-engaged approach to implement and evaluate behavior change interventions across a comprehensive list of health priorities. Dr. Irvin is currently the chair of the Public Health Advisory Board. And then, last but not least, we have Colin Peterson, who is a health policy doctoral student in the College of Public Health and Human Sciences at Oregon State University. His research focuses on economic evaluation and establishing value of care for healthcare professionals, especially in the field of athletic training. Colin is also a licensed athletic trainer in the state of Oregon. So welcome to all 4 of our presenters. Thank you for being here and engaging us with this important work. I believe I'm going to hand it over to Tao to kick things off with the presentation. And we'll go ahead and bring up the slides for you, Tao.
Thank you very much, Tara. Good morning, everyone. Thank you very much for having us today to present our report of the Oregon's Healthcare Workforce Needs Assessment 2023. Our team at Oregon State University collaborate and work closely with Mark, Neelam, and Craig, the project advisory group, the workforce committee, and all content experts to develop this report. We greatly appreciate all their support. We presented our report to the Healthcare Workforce Committee last week, and we would like to thank the committee for their very helpful comments and discussion. We edited our slides, and we will highlight a few recommendations per the committee's comments and suggestions in this presentation. Next slide, please. Oregon has long been working to transform its healthcare system to ensure that all people in Oregon can reach their full health potential and well-being. Oregon's goal of eliminating health inequities requires the preparation, recruitment, and retention of a diverse workforce. In 2017, the Oregon's legislature passed House Bill 3261. This bill provides guidance and requirements associated with Oregon's incentive programs to attract and retain healthcare providers to work in underserved areas of the state. The bill also directed the Oregon Health Policy Board and OHA to produce a biannual assessment of the healthcare workforce needed to meet the needs of patients and communities in Oregon. The 2023 Healthcare Workforce Needs Assessment will be the fourth report published by OHA. The purpose of this report is to inform investments going forward. We use OHA's annotated outline and summarized existing data to develop this report, and we appreciate your feedback and questions after our presentation. Now I will pass to Colin to report the investment section. Colin, please.
Next slide. So Oregon has made a concerted effort to expand existing investments and make new investments in programs that help expand the healthcare workforce since the last healthcare workforce needs assessment. Existing programs like the Healthcare Provider Incentive Program, which includes loan repayment, loan forgiveness, malpractice subsidies, and the scholarship incentives, as well as other incentives that are a part of the Healthcare Provider Incentive Fund, had received additional funding, as you can see in the table. I also included some highlights on the next slide for the Rural Medical Tax Credit and Healthy Oregon Workforce Training Opportunity Grant Program, or the How-To Grant Program, which are part of the Healthcare Provider Incentive Fund. The Behavioral Health Workforce Initiative, which was created over the past 2 years and is also part of the Healthcare Provider Incentive Fund, will be talked about in the behavioral health section. These incentives continue to build healthcare workforce capacity in rural and underserved areas across a variety of provider types, and have only become more important with recent shortages that have been exacerbated by COVID-19 and will be highlighted by the rest of our team. Next slide. So investments have also been made outside the Healthcare Provider Incentive Fund. The OHSU 30-30-30 plan and Future Ready Oregon hope to increase education and training capacities for healthcare workers, while also increasing the diversity of the future healthcare workforce. Our recommendations regarding investment include continuing to work with the public workforce system and allied educational partners to continue to invest in workforce training, and continuing to fund financial incentives like those in the Healthcare Provider Incentive Program and Healthcare Provider Incentive Fund. These remain important tools to addressing workforce shortages. It's also important to evaluate and monitor the effectiveness of current incentive programs. Measures like cost per placement year across different healthcare professions and retention effectiveness can help evaluate the effectiveness of incentive programs in achieving their goals of addressing workforce needs and inequities in underserved communities. This is important to ensuring the best allocation of resources and how incentive design can be adjusted to improve future health outcomes. Finally, investment must address other factors that affect recruitment and retention outside of workforce-related financial needs in rural areas. Things like housing costs and supply, economic opportunities for partners or spouses, and K-12 education needs have been mentioned as recruitment barriers. While we have limited data specific to this area, this has been mentioned by content experts and in other meetings as important factors, and additional data should be collected in this area in the future. And I will pass it back to Dr. Lee.
Thank you, Colin. Next slide, please. Healthcare workforce burnout is a long-standing issue, which has been exacerbated by the COVID-19 pandemic. A national survey found that over 60% of physicians reported burnout in 2021, compared with only 38% in 2020. As of November 2021, over 70% of Oregon primary care providers reported that mental stress in their practices at an all-time high, compared to around 60% at national level. The study by Oregon Center for Nursing found that 83% of nurses reported stress. Health worker burnout can have many negative consequences. A national survey found that more than 30% of nurses who left their job reported burnout as a reason. The study estimated the national cost for burnout-related turnover at $17 billion for physicians and $14 billion for nurses a year. Next slide, please. There are national and state level investments and programs to improve workforce resilience. Just a few examples here. In 2021, the US Department of Health and Human Services allocated $103 million to be spent over a 3-year period to reduce burnout and to promote mental health among the health workforce. The passage of the Dr. Lorna Green Healthcare Provider Protection Act in 2022 established grants and required activities to support the mental and behavioral health of health workers. For example, it established grants for training health professional students, residents, or health professionals in evidence-informed strategies to reduce and prevent burnout. In Oregon, the Oregon Center for Nursing launched the RN Wellbeing Project in 2021 to aid workplaces in developing interventions that are necessary to improve nurses' mental and emotional well-being. OCN is working on innovative solutions for employers to make systematic cultural change to best support their nurses. OHA is also taking various steps to support behavioral health providers. More details are provided in our report. Next slide, please. A range of social, cultural, and organizational factors can contribute to healthcare workforce burnout. Therefore, systematic changes and collaborative action are required to prevent burnout and improve well-being. In October 2022, the National Academy of Medicine published a national plan for health workforce well-being. It calls on multiple actors to cultivate a health system to support care providers and optimize their well-being. The 2022 U.S. Surgeon General's advisory also called for collaboration from a variety of public and private stakeholders to tackle healthcare workforce burnout. We highlighted some recommendations here. Sustain a positive work environment and culture, make workplaces more welcoming for diverse providers, support healthcare workers seeking mental health care, and invest in research to inform evidence-based strategies. Next slide, please. The impact of COVID-19 on reduced healthcare visits and healthcare employment were greatest during the first months of the pandemic. Healthcare visits reduced significantly in April 2020. The reduction in healthcare visits and revenues led to layoffs. The pandemic also exacerbated healthcare workforce burnout to an alarming level. States took a variety of actions to address healthcare workforce needs. Healthcare facilities also greatly increased their use of temporary staffing agencies, and the cost for temporary staff increased dramatically. The public health workforce was increased during the COVID-19 pandemic. In Oregon, between March 2020 and August 2021, FTE of local public health authority workforce increased about 70% for the COVID-19 response. Next slide, please. Current employment estimates show a rapid reversal of pandemic recession job losses. Within the healthcare sector, employment trends varied. Employment in ambulatory healthcare had bigger declines in spring 2020, but has had a stronger growth since then. The number of people employed in ambulatory healthcare declined 17% from February to April 2020, but had rebounded to pre-pandemic levels by August. On the other hand, there was slower but steadier decline in employment by hospitals and nursing and residential care facilities. As of August 2022, the number of people employed in these two sectors was still about 5% lower than pre-pandemic levels. Next slide, please. This figure shows the number of monthly online healthcare job postings. In May 2020, the number of monthly postings was about 1/3 lower than pre-pandemic levels, and the number of job postings began to rebound by July 2020. There were about 17,000 online healthcare job postings in September 2022, which is about 9% higher than a year ago. Next slide, please. The fast job recovery, low unemployment, and high number of job openings have all increased difficulty for employers seeking to hire. A recent report by Oregon Employment Department showed difficulty filling healthcare jobs, as healthcare occupations represented nearly 10% of job vacancies in Oregon. Therefore, policies should expand education and clinical training opportunities to support workforce development. such as ensuring adequate number of faculty and clinical training placements for nurses and other licensed professionals, establishing and funding clear career pathways, and investing in a mix of reliable and new strategies to enhance training opportunities. Next slide, please. Dr. Jeff Luck will report telehealth section. Jeff, please.
Thanks, Tao. So telehealth is one important way to increase access to a limited healthcare workforce. At the beginning of the COVID pandemic, telehealth utilization jumped from almost nothing to an average of about 1 in 10 Oregon health plan visits over the last 2 years. More than half of those visits were for behavioral health, and about a quarter were for primary care. And despite concerns about potential disparities in access to telehealth, utilization of telehealth was fairly even, ranging from about 8 to 10% of ambulatory care claims across all major racial ethnic groups who are members of the Oregon Health Plan. However, OHP members in rural and especially frontier areas had much lower rates of telehealth utilization than members in urban areas. Now, one of the reasons that telehealth utilization rose so quickly during the pandemic was that Medicare and Medicaid and private insurers relaxed their restrictions, their previous restrictions on telehealth reimbursement. Oregon has, through legislation and regulation, made those looser restrictions permanent. However, the federal restrictions, such as using Skype or Facebook for telehealth, may become tighter again when the public health emergency expires, probably sometime in 2023. In terms of policy recommendations for this board, we would highlight the importance of using real-D data to understand potential disparities in telehealth use and promote access by all groups, and especially ensuring access to telehealth for rural and frontier residents of Oregon. Next slide, please. Now, with regard to Oregon's nursing workforce, our team drew heavily on the excellent report recently prepared and presented by UCSF and the Oregon Center for Nursing. And in addition to describing the characteristics of Oregon's workforce, that report highlighted a couple of important findings. First, that Oregon increasingly depends on nurses who are trained in other states and then seek licensing in Oregon. And second, oh, thank you, Tara. Tara just put the URL for that nursing workforce in the chat, that nursing report in the chat. And then the geographic distribution of nurses in Oregon, unfortunately, does not match the needs of the population, especially in many rural areas. And then the COVID-19 pandemic, put incredibly heavy demands on nurses, and actually led to the shortages that we're experiencing today, especially in hospitals and nursing facilities, as Tao's slide showed. UCSF and OCN made a wide range of detailed and specific recommendations. I'll just highlight a couple of them. First, to support employers in creating healthier work environments to retain nurses. And second, to strengthen Oregon's nurse training pipeline at all stages, colleges and universities, clinical placements, and apprenticeships. Next slide, please. So Oregon also has a growing need for a workforce to care for patients in their homes and in long-term care facilities on an ongoing basis. That need will grow rapidly over the coming decade. But long-term care workers are usually women. They're often persons of color or immigrants. They are usually low income. And these workers have long faced several major challenges: low pay, high turnover, and limited opportunities for advancement. COVID, though, absolutely slammed the long-term care sector. Workforce shortages became severe and persist today. And for example, workforce shortages at nursing facilities are causing backups in discharges and admissions at Oregon's hospitals. Now, DHS and OHA have taken several short-term steps to mitigate these problems. The nurse crisis team, for example, provided staff to long-term care facilities, and additional funding was made available for long-term care facilities. But DHS recently commissioned PHI to produce a report of with longer-term recommendations, and those strategies focused on improving compensation for long-term care workers, strengthen their training opportunities and career pathways, and also improving their workforce environments. And now I'll pass it to Dr. Irvin.
Good morning. Thank you so much for having us. Next slide, please. I'd like to talk today about traditional health workers who are trusted individuals from their local communities who provide person and community-centered care by bridging communities and the health systems. Examples of specialty types of traditional health workers in Oregon are community health workers, peer wellness specialists, peer support specialists, personal health navigators, birth doulas, and recently tribal traditional health workers. And as of October of this year, there are about 4,400 traditional health workers who are certified and on Oregon's registry. Traditional health workers in the state are still underpaid, underrepresented in certain groups and regions of the state, and underrepresented in persons of color relative to Oregon's population. CCOs must include strategies for integrating traditional health workers into the delivery of services, and OHA has launched a toolkit with information for health systems and providers on how best to facilitate integration of traditional health workers. There's also been some recent funding for community health worker programs and traditional health worker programs, specifically by OCHN. Sorry, my light just went off in my room, and the Coalition for Local Health Officials. Recommendations for traditional health workers include increasing compensation, improving reach to all counties across the state, and different strategies to recruit, train, and maintain traditional health workers. Next slide, please. Healthcare interpreter workforce. They are bilingual individuals who help people in their communities with limited English proficiency or persons who communicate in sign language. They also must have formal training and pass national certification exams. There's about 1,200 qualified and certified interpreters in Oregon, with about 30 different languages spoken. As you'll see, Oregon Health Authority has increased the number of certified healthcare interpreters by removing application fees, streamlining the application process and other requirements. There are still some recommendations, including changes to compensation, increasing a 2-hour minimum, reimbursement for patient no-shows, and improved training across the state and technical assistance for providers. Next slide, please. Oral health providers, that includes dentists, dental therapists, dental hygienists. I think I just got muted. Okay, there are 5 types of dental oral health providers. And in 2022, OHA received an oral health workforce grant to help expand services to certain rural counties, including expanding teledentistry, offering mobile dental van visits, and expanding different ways to incentivize dental preceptors. There are recommendations for this workforce, including identifying pathways for dental hygienists to grow into dental therapists, recruiting a more diverse workforce, allowing flexibility in licensing, and improving the reach across the counties, provider incentives, mobile dentistry, and teledentistry. Next slide, please. And lastly, I'll be talking about the public health workforce. This includes federal, state, local health authorities, tribal authorities, as well as community-based organizations. There's approximately 1,000 current staff with Oregon Health Authority Public Health Division. There's 33 local public health authorities across the state. During some recent funding through COVID sponsored by OHA, they funded more than 170 community-based organizations to provide culturally and linguistically responsive services. Public health funding has been underfunded before the pandemic. However, the legislature has been starting to invest in public health modernization funding, and there has been some recent grants application through Oregon Health Authority for infrastructure and workforce development. Final recommendations for public health workforce include there's really a shortage, again, across multiple counties, especially in rural and frontier, especially among epidemiologists. So the idea about doing some homegrown workforce professionals, doing more reach outs to K to 12 education, providing more online health education, including certificates, and trying to recruit and retain the current workforce with salary adjustments and other ways to incentivize the public health workforce. I'll stop there. And I'll pass it over to Dr. Lee.
Thank you, Dr. Irvin. Next slide, please. Primary care providers not only care for patients, but also perform health promotion, disease prevention, and patient education. Primary care providers play a critical role during national health emergencies like the COVID-19. Studies showed that residents in communities with greater primary care access had better COVID-19 related outcomes, such as less likely to get infected or die from COVID-19. The COVID-19 pandemic has also highlighted the long-standing problems like underinvestment and workforce shortages in primary care. High-quality primary care is the foundation of a high-functioning healthcare system. The 2021 report by the National Academies of Science, Engineering, and Medicine made recommendations to achieve high-quality primary care and rebuild a strong foundation for the U.S. healthcare system. In Oregon, the Patient-Centered Primary Care Home Program is part of a comprehensive statewide strategy for health system transformation. This care delivery model fosters strong relationships with patients and their families to better care for the whole person. There are over 600 primary care practices in Oregon that participate in the PCPCH program, and more than 3 million people living in Oregon receive care at a PCPCH. We recommend Oregon to further improve PCPCH to emphasize health equity and support a high-quality patient-centered primary care system. Next slide, please. Behavioral health services are an important component of whole person care and are provided by a variety of practitioners. The behavioral health system has been faced with a severe workforce shortage. Studies show that over 60% of Oregon healthcare providers reported their organizations needed more behavioral health providers. And 76% stated that it is very important to expand Oregon's capacity to train and develop more behavioral health professionals. There are several national and state efforts to address behavioral health workforce shortages. In Oregon, the legislature allocated more than $1.35 billion in funding for 2021 to 2023 to transform Oregon's behavioral health system. The Behavioral Health Workforce Initiative seeks to provide incentives to increase the recruitment and retention of providers in the behavioral health workforce, with a focus on equity and priority population. $60 million was allocated to develop a behavioral health workforce through scholarships, loan repayment, and retention activities. $20 million was allocated for a grant program to license and certify behavioral health providers to provide supervised clinical experience to associates and other individuals so that they may obtain a license or certification to practice. In 2022, the legislation provides $132 million general fund investment for OHA to distribute grants to behavioral health providers to increase compensation to staff and pay hiring and retention bonuses. In addition to increased wages, it is also important to reduce administrative and other workplace burdens to prioritize health worker well-being and increase the recruitment and retention of providers with a focus on equity. Next slide, please. In addition to the recommendations for each specific provider type, we provide general recommendations to support overall workforce development. In particular, the Healthcare Workforce Committee gave us very helpful comments and feedback at our presentation last week. Per their inputs, we selected a few recommendations to highlight as priority items below. Additional recommendations are included in our report. First, improve the diversity of healthcare providers. We recommend using the health equity framework to infuse equity into workforce development policies and programs. Second, improve the supply and distribution of the healthcare workforce, such as continuing to fund financial incentives to increase opportunities for training, education, and practice, such as those in the Healthcare Provider Incentive Program, and addressing social and economic factors that influence workforce recruitment and retention, especially in rural and frontier areas, such as housing costs and supply, economic opportunities for partner and spouse, and quality of K-12 education. Third, enhance the resilience and well-being of the healthcare workforce. It is important to invest in interventions to address burnout and well-being with focus on societal, cultural, structural, and organizational factors. It is also important to sustain a positive work environment and culture and reduce workplace burdens. Fourth, expand training, education, and career pathways for many segments of the healthcare workforce. We recommend investing in Oregon's education pipeline for healthcare professionals, including K-12 outreach, community college, bachelor's, online certificate, and education programs. Next slide, please. Regarding care delivery models, we recommend expanding telehealth coupled with healthcare interpreters to ensure access for people needing culturally specific and linguistically appropriate services. For community-based healthcare providers, it is important to find ways to increase compensation for traditional health workers, healthcare interpreters, and peer wellness specialists who are underpaid and are underrepresented in certain regions of the state and among persons of color relative to Oregon's population. Finally, we find it very important to improve data collection to promote evidence-informed strategies and diversify the healthcare workforce. At our presentation to the Workforce Committee last week, we discussed a range of social and economic factors, such as housing costs and supply, quality of K-12 education, and other neighborhood and community features. Although these factors may all contribute to workforce shortages and maldistribution, there is still currently lack of data for us to assess the complex impacts of these factors on workforce development, especially in the healthcare sector. Therefore, we recommend investing in collecting data that can improve our understanding of social and economic factors that can influence healthcare providers' decisions and can influence workforce recruitment and retention. We also recommend including more provider types in future workforce needs assessment. Next slide, please. Workforce shortages and lack of diversity in many areas of healthcare are a national problem experienced in Oregon. The legislature has recently made critical investments in supporting the state's healthcare workforce. The impact of these workforce investments has been significant, but there's still more to be done. Additional resources are needed to address workforce shortages and maldistribution in order to meet OHA's 10-year strategic goal of eliminating health inequity. In summary, our reports show that some workforce clearly need pay increases, many have unclear career pathways, and all need more work around resilience. Next slide, please. Again, we would like to thank OHA, the Project Advisory Group, Workforce Committee, and content experts for all their support to our work. Specifically, we would like to thank Mark, Needham, and Craig again for all their support to us. Thank you again, and we appreciate your comments and questions.
Great, thank you to all of our presenters. We really appreciate it. And just so people know, there's a couple of resources that I dropped in the chat throughout the presentation. So if any of those aren't working for you, or if you have any questions about those, please let myself or Mark Overbeck know. All right, so I'll open it up. Let's open it up first for any members, Oregon Health Policy Board members that have any thoughts, comments, questions to share. And then if other people are interested in making comments or have questions, please raise your hand or send me a chat so I can get a queue started. Okay, I see Brenda, you have your hand.
I'll go, boy, this is the second time I've heard this presentation, and I am so grateful for the comprehensive nature of what you've prepared for us. So thank you very much for your hard work. I have two questions. The first is around, Dr. Lee, feel free to punt this, or Dr. Luck, Dr. Irvin, wherever you'd like. The first question is, around the data collection recommendations, specifically whether or not we have line of sight into the employer workspace around the demand. You know, I understand from the employment department what information we have available. Do we have methods of understanding from the healthcare employers who they want to hire, how often they want to hire, specifically the groups of people they want to hire? Thank you. And then I have a follow-up question after that.
So Jeff, do you want to go ahead to respond to this?
Well, sure, I can say a little bit about that. I think the short answer is no, we don't know as much as we would like. Like, for example, with regard to long-term care, we know there are vacancies, but sort of the more details about the type of those vacancies and the length of them would be appropriate. So I think you really hit on something that several of our content experts identified as important for policy, understanding more clearly what employers are looking for, what they're having difficulty finding in the job market.
Mark, do you want to add some comments here?
Thanks so much, Tao. Agree with what Jeff said, and also I wanted to mention, Brenda, you certainly may recall that in previous versions of the needs assessment, we did include different lenses of need, and one of those was from the employer perspective. The employment department certainly does do provider surveys frequently, and they capture those as part of their monthly updates. So we do have some information from employers around what they're projecting. I do want to say that employer-specific information often needs to be qualified, because there are projections and then economic circumstances don't go exactly the way that the employers are hoping that they will go, and then they'll cut back on their workforce. But certainly the employer surveys from the employment department are one good source of assessing at least what employers are thinking they're going to want in the future.
Yeah. So Mark, just to clarify, so what they collect is not real-time data. It's not data that's specifically, like, at any given moment, a hospital could say, we're currently in the process of recruiting X many nurses. That is not a process that we have in play in the state. Is that correct?
I'm not sure about the real-time data. The employment department does go and survey employers on a regular basis around what they're anticipating. That does include current vacancies.
Okay.
So they will be able to tell you current vacancies. What we found, though, is the current vacancies aren't necessarily what they can fill, and not necessarily even what they will hire.
Right, right. So understanding the real gap from the, I understand the supply side. What I don't understand is the demand side, and just curious how we could get more systematic review of that, so we understand the gap that we're attempting to close in the very disciplines that this report isolates or highlights for us. Yeah.
Great, Brenda, and maybe a session with the workforce committee or interested parties with Gail Krummenauer, like the lead labor market information specialist, data specialist from the employment department, would be helpful.
That'd be great, Mark. That'd be really great. I'd love to take it back there with you and see what we could do to get a little bit more systemic review
Sure.
of it.
Yeah.
Even if just while we're in crisis mode, if it's quarterly, if there's something we can organize to understand if we're making progress. Yeah.
Sure. And Neelam also in the chat that there's also the Help Wanted online data, but I think organizing what you're saying to get a better sense of what do we know about the demand, we can put that together.
Yeah, I imagine employers would be helpful and, in their own self-interest, wanting to participate so we can have a better view of what the needs really are from that perspective. That'd be great. Thanks, Mark. My second question is around the recommendations. And I'm curious if either in the research itself or in the review of material, we thought about reduction of administrative burden as one of the recommendations related to resiliency. I think it's one of the things we recognize in provider groups. We can make recommendations like you're describing here, and they may not have the layer of specificity in such an abstract concept, not so abstract, very real, but understanding how to actually measure improvement in resiliency and retention through the lens of what specific activities. So I think there's a question embedded in there. Did your review highlight specific recommendations around reducing administrative burden?
Thank you very much, Brenda. Yeah, I do have some details actually in the report, and I would like to give just one specific example that now I remember as one of the One of the steps that OHA is taking to support the behavioral health providers is to reduce their, the administrative burden for the behavioral health providers. And also there are some national guidelines and recommendations that I included in the report. Also mention the importance and provide some actionable items that multiple sectors should take to reduce administrative burden. And this is highly related to sustain a positive workplace culture and making the organizational change. Yeah.
Thanks. I'll look forward to scrubbing the additional detail to find additional.
Thank you.
Oh,
sure.
Thank you so much. Yeah.
Yeah, actually, the U.S. Surgeon General, I'm just looking at the U.S. Surgeon General's advisory. It mentions that reducing the administrative burden and other workplace burdens to help help workers make time for what matters. So we do include that in the report. Thank you, Brenda.
Great, thank you. I see John Santa, Oregon Health Policy Board member. You have your hand up, so go ahead, John.
Yeah, thank you. You all, that was really informative. But a picture is worth 1,000 words. And when I saw the slide with the graphs on what happened to the ambulatory workforce, to the hospital workforce, the long-term care workforce, I'd seen it before, but it's just stunning. What happened to the ambulatory workforce? I don't think those people quit. I think they were laid off. I mean, we were totally unprepared for an event like a pandemic when it comes to ambulatory care. And I personally believe that there was a huge difference in the response of folks on the private side. Frankly, I think some folks on the private side saw a fire and ran towards it. Some of our CCOs saw a fire and ran towards it. I think the state saw a fire and ran towards it and did everything it could to get the remote stuff up and going. But I think other folks did not. Other folks saw a fire and, ran the other way. And, as a board member, I'd ask my colleagues whether that's something that we need to look at going forward. As a primary care person, sorry, it'd be pretty hard for me to feel secure or resilient when I look at that graph. I think you all did a great job of describing, for the most part, what public organizations should do. But that's not the system we've got. We've got a public-private system. And I think we need recommendations on what private systems should do. And when this happens the next time, we need to have laws that require them to do it. I just want to preserve that graph for the Oregon Health Policy Board. And at some point, we need to learn from the pandemic what happened. And something like that just can't happen again if we truly value primary care. So appreciate your presentation.
Thank you very much. Thank you very much, Dr. Santa. And I think, like I mentioned and also highlighted in our report, primary care providers definitely play a very critical role during some, public health emergencies like COVID-19. And I think the COVID absolutely, highlight some long-standing issues like underinvestment in primary care. So we do make some recommendations in our report to specifically, to call for multiple sectors like public and private sectors for their collaborative action to address this workforce shortage, and especially the maldistribution. Thank you again for your comment.
Great, thank you. We do have a chat question that came in, so I don't see any other members with hands up So I'll go ahead and read this, and whoever feels like they can answer it, go for it. The question is, I would like to know how the system takes responsibility for resiliency rather than placing responsibility on the individual.
Would you please repeat that question again, Tara? Sorry.
Yeah, sure. And if the, it's from B. Grace Bullock. So if there's additional context to add, this is all I have. They would like to know how the system takes responsibility for resiliency rather than placing responsibility on the individual.
Thank you very much. Yeah, we heard that comment also at our committee's presentation last week, and we fully agree that actually we include some detailed discussions about, you know, how different factors like social, cultural, organizational, and structural factors may all contribute to workforce burnout. And so we also make some recommendations, specifically follow some national plans and the U.S. General's advisories to call for systematically changing, you know, the workplace environment, and to make sure that to address the workforce resilience and to support workforce well-being at a systematic level and organizational level, rather than putting it on just individual responsibility. Jeff and Veronica, do you have anything to add?
It strikes me that both Dr. Santa's question and that question are really getting at some of the same themes of,
Yes.
of system level
Yes.
preparation and system level response to crisis situations. So I think that's it's really, I mean, if the policy board and it's, you know, that's exactly the sort of thing that this body is really able to highlight.
Yeah, and also like what we included in the report, both the efforts at the national and state level, the national and state level efforts, they all highlight the importance of making efforts to address the societal, cultural, and organizational factors that contribute to workforce burnout, rather than putting on just individual level. Thank you, Tara.
Great, thank you for answering that. I see we have a hand up. See, looks like Sandy Sampson, Oregon Health Policy Board member. Go ahead.
Thank you, Tara. Thank you for the report. I guess there was a couple questions I had in regards to care delivery models to improve patient access and workforce retention. With the traditional health workers, you had stated that to increase compensation for traditional health workers, healthcare interpreters, peer wellness specialists, because, you know, I guess working with numerous legislation in regards to that, is there a way, or did you do any research in regarding, you know, the lived experience and how the work is promoted within the community that they live in? I know as far as tribal organizations, we pushed this back in 2017 to do a peer support specialist curriculum for just for Native Americans. So on that data collections for that, what was the outcome that would be advised to increase that workforce retention?
So what are some strategies to increase workforce retention among traditional health workers?
Yes.
Yeah, so, and just a question you had about data collection, there was done actually this last year, a survey that was done through the Oregon Health Authority Traditional Health Worker Survey. So they do have a lot more details and that those are publicly available about the traditional healthcare workforce experience. I think that when you look at, there's some maps that are in the larger report that we did, and you'll see that it's very different based off type of traditional health worker, so where they are throughout the state. And that peer support specialists are, for instance, are concentrated on certain areas, peer wellness specialists, certain areas of the state. And so there's different shortages across different regions of the state. So I think there is a request looking for increased compensation to maintain some of the traditional health workers. There's also a request to do some more training regionally or locally to recruit and from those areas. So increasing some of the workforce development and training programs in other counties. And I believe that's what some of the recent funding for OCHN and the Oregon Coalition of Local Health Officials. I don't know if I answered your question, Dr. Sampson.
No, you answered it. I just was curious because when we started the traditional, just for the, we had a traditional health workers curriculum built just specific to Native Americans back in 2017. It was approved in August of 2017, and we've been doing it for, I don't know, 5 years, 6 years. But I was just curious, how do you promote it within different cultures, the Hispanic culture, you know, other cultures that fit some of their traditional values, cultural values, to, you know, to get certain curriculums developed for their specific areas, for their, you know, for their communities?
Yeah, Veronica, if you don't mind, may I add a
Yeah,
comment
go right
here?
ahead. Thanks, Sal.
Yeah. As what we highlighted in our slides, also in our report, we recommend using the OHA's and OHPB's health equity framework to infuse equity into workforce development programs. So I think that framework will be a very helpful tool and starting point to help train healthcare workforce that can provide culturally and linguistically responsive care to the local communities.
Thank you.
So, Urban, do you have it? Yeah, thank you.
I was just gonna say there is, and thank you for bringing out Native American. There has been, that was tribal health, traditional health workers among tribes has been added as one of the traditional health workers certified for the state. And again, there has been, I think, a movement to add more trainings recently, a lot more curricular trainings, but how to reach certain groups in certain counties. I'll be honest, I don't have that detailed in this report and would like to offer ideas for ways to improve that. So thank you for mentioning that.
Thank you.
All right. Thank you. Thank you, everyone, for joining us this morning, and special thank you to our presenters. Thank you for all your hard work and bringing this information to us. We greatly appreciate it. Before we close out, I know we had one little announcement from Bhagavati, and if you want to unmute and share.
Thanks, Tara. Yeah. I know that RN Wellbeing Project was referenced in the research, and I just wanted to call out that there is a grant, a mini grant opportunity open at this time through January 20th. And Tara's going to drop the link directly into that. And just wanted to highlight that 10 of the 17 mini grants that will be awarded will be going out to long-term care in particular. So please do check that out and spread amongst your contacts. Also just calling out that Neon has some wellness at work supports as well that I'll share with Tara, and she can send that email back out to people as she sees fit. But if they're relevant to the traditional health worker and a lot of the things that have been discussed, and I'll put the link to that.
Great, thank you for that announcement. And I'm dropping the second link in the chat right now, so you all have that. And we're gonna go ahead and wrap up today's educational webinar. The video recording will be available on the board's website either later today or tomorrow if you want to reference that. And if you have any follow-up questions, please feel free to contact me, Tara Chetok, the project manager for the Oregon Health Policy Board, or Mark Overbeck, who leads the Healthcare Workforce Committee. Thank you, everyone. Have a great day and great rest of your year. Yes, please, go ahead.
Thank you, Tara.
Oh, okay, sorry, I thought you had one more announcement. Okay, you are so welcome. Thank you, everyone.
Bye.
Bye.
Thank you. Bye-bye.